All right, welcome back to the OR. We are ready with surgery 2 by Peter De Alessandro from Perth, Australia. So his patient is a 31-year-old male who's a farmer, well built, no comorbidities. He sustained a fall from a motorbike about 2 months back. He did not have any bony injury. However, he developed instabilities and now he's unstable even on performing activities of daily living. He does complain of pain on squatting and prolonged walking and his farming activities. So on clinical exam, there is no effusion in his knee. The range of motion is about 120 degrees, beyond which it is painful. The ACL is grade 3 unstable. There is grade 3 anterolateral instability as well. Corners collaterals are okay, and McMurray's was not performed because he's quite painful on deeper flexion. So that's his radiograph showing neutral alignment, the Mikulicz line right bang in the center. He does have a normal posterior tibial slope, 8.4 degrees. And that's his MRI, the sagittal section showing a lateral meniscus tear, the ACL tear, and a probable ramp lesion as well. So that's the ACL injury that we can see. It's a femoral sided peel-off sort of injury. He does have some signal in the anterolateral capsule as well. The lateral meniscus demonstrates an oblique radial tear. This is a relatively recent description of the lateral meniscus tear type, which is slightly away from the root, and this has been described by Aaron Krish from Mayo Clinic. So this patient looks like a type 3 lateral meniscus oblique radial tear. He also does have a medial meniscus ramp lesion, signals predominantly in the meniscocapsular side. And that's again the ramp signal seen on the axial view. So the plan is to perform a right knee ACL reconstruction along with a medial meniscus ramp repair and the lateral meniscus repair. And Peter will walk you through his case plan.
Hi, it's Peter De Alessandro here from Perth in Western Australia, and it's a privilege to be here for my first time in India as part of this historic event. Today's live surgery is on a patient who I met yesterday, who's a farmer with an ACL deficient knee and meniscal tears on both sides. My plan for him is a hamstring ACL reconstruction. I certainly am someone who likes using all grafts depending on patient factors, but he has relatively neutral alignment and is not a high risk patient, therefore a hamstring ACL seems appropriate for him. Whether I take 1 or 2 tendons will really depend on tendon size. We've just finished a randomised controlled trial looking at the differences in donor site, and there is a significant difference when we take 2 versus 1. So a single tendon reconstruction is my preference, but if it's insufficient to achieve a size 8 graft, then we'll take a gracilis as well. Today's fixation, we're going to use adjustable buttons, so ultra buttons on both sides of the joint. And so my plan today will be, we'll scope the knee, we'll assess the notch, we'll clear out the notch. Unlike Camillo, and it's nice to have many different ways of doing the same thing, I'll be drilling from the inside, from the anteromedial portal, and we will aim to replicate the AM bundle with a socket of approximately 25 millimetres. We'll then do a standard tibial tunnel with, as I said, adjustable fixation on both sides of the joint with a extendo button on the tibia. In terms of the menisci, and you'll have seen the images in terms of the menisci, he has 2 significant meniscal injuries. Certainly on the lateral side, we can see that he has what looks to be a complete radial tear, probably a Risberg variant near the meniscal root, but not quite near enough to do a root repair. We'll do a root repair if we need to, but almost certainly we'll need to do some sort of side-to-side fixation supplemented with vertical fixation. So the plan will be some sort of hashtag repair, stabilising each part, the root side, the body side, and then likely side to side across that using either a combination of fast fix flex and potentially Nova Stitch. We'll use a number of portals for that. Finally, on the medial side, he has signal at the posteromedial part of his knee, indicative of a possible ramp repair, ramp lesion. So we'll do a pie crust of the MCL. Very important to get appropriate access to the posterior medial part of the knee. We'll look at the back and then we'll fix his ramp if we need to. I look forward to seeing you in the OR. Hi everyone.
Yes, Dr. Peter, you're on.
Thank you. And can I say what a great session that we've just been watching. I learnt a lot while we were here scrubbed, so thank you for having me. In terms of my plan, we've already taken our hamstrings, and sure enough, the semi-T was a touch small, so we took the gracilis as well. Gracilis wasn't great either, classic heart sink live surgery moment, but we've achieved a size 8 graft on the femoral side, size 9 on the tibial side, which is terrific. So I'll just take you through what we can see inside this knee. We can see here, we've talked a lot about stump preservation, but there is a stump and that is moderately preserved at the moment. If we just give it a little pump there, guys, a bit of fluid. I've already done a little notch plasty. Again, big fan of creating a notch that allows me, A, to get nice access, but B, doesn't impinge. And I always use my PCL as a guide. North-south, my PCL, and I like having my lateral condyle parallel to that. Looking at the back of the knee, we've marked out our femoral tunnel already. So in terms of position, we can see we're at about the 10 o'clock position. Back wall, I've marked it with a chondral pick, as we can see here. And then I always swap portals to assess my position to make sure that I'm happy with that. Nice, thank you. Thank you very much. As we can see here, so we'll have a look. I feel like I'm appropriately off the back wall, but certainly sitting nicely in the AM position. So I'll take you through his meniscal injuries. We'll go to the medial side first, and I'll get my probe here. So he's got nicely preserved chondral surfaces. Doesn't look like he's got much going on in terms of his medial meniscus, but certainly I'd encourage you all, particularly where you see bone edema on the MRI, and what we can see there, always have a look posteromedially. So put the knee into slight varus, have a look back posteromedially, and here we can see, you know, it's a relatively low grade ramp. If I can't see enough, I'll switch to a 70-degree scope. We don't need to do that today, but I think we've got enough of a deficiency of the meniscocapsular junction to call that a ramp. Now, we're going to fix this all inside. If it was high grade, I'd do a posteromedial portal and we'd repair from the back, but we're not going to need to do that. And then I'll just quickly take you to the lateral side. And again, thank you to the guys for a nice complex lateral meniscal tear. As we sort of thought from the scan, there's a fair little pump, guys, a little bit of complexity to it. We're not going to do blood clot augmentation, but would be happy to if we needed to. So what do we see? We've got a complex horizontal component, which we can see through here. And then if we have a look at our root attachment, we have this Risberg variant, or as we said, as Aaron described, a type 3, which is pretty much complete. And the majority of the root is attached to this here. So we are going to aim for a side-to-side component to that. So it'll be a combination of vertical matrices and side-to-side. If we're in trouble, we're happy to switch to a slightly non-anatomic root repair using this component there, but we'll deal with that in a little while.
So Peter, will you be planning something for the horizontal cleavage that is present in the lateral meniscus, or would you like to leave it?
No, absolutely. So my plan will be, we'll fix the horizontal cleavage. Because it's a double cleavage, we'll do almost round the world suturing using Fast Fix Flex for those. So I'll do that first to stabilize the body, and then we'll switch to the root component to go side to side.
So Peter, any tips and tricks in terms of order of operation? So in terms of, I can see right now you're looking more into the femoral side of the ACL. Any consideration of doing your meniscus first, or medial side, lateral side, ACL? What is your thought process?
Yeah, I think that's a great question, and I think that's something that's evolved as my career has gone on. We've often been told, do the menisci first. The menisci are going to be challenging here. I don't want to be hyperflexing the knee once we're done, so I'm actually going to drill my tunnels. Then we're going to go to our menisci, pie crust. We're going to do the medial side, and then the most difficult, the lateral side. So we can see here, I am going to do the femoral tunnel ACL. I've got a solid 4.5 millimeter drill. I've got my pilot position here. The guys are flexing up now for me. Thank you very much, guys. Flex, 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 flex. Bit more flexion there. That's great. Thank you. So I'm going to use my solid 4.5 drill.
So Peter, this patient is having a grade 3 pivot as well. So do you think the root and the ramp is responsible and you will not go ahead and add a LET in such case?
Yeah, another great question. I felt like his pivot was maybe not quite grade 3. I thought it was sort of a 2 and a bit. If his patient factors told me that he was higher risk, then I absolutely would. I have a high LET rate. But for him, as a relatively low demand patient, he's not meeting my criteria. So we can see here, I'm actually feeding the guide wire on hand. Something I learnt during my time on fellowship in Vancouver was this docking technique. So to avoid hitting the medial femoral condyle, we'll actually dock inside the knee. So flex up now, guys. Well, what I didn't do, excuse me, didn't use my depth gauge. Let's do that first. I'll measure just take that one out. Yeah, great. Just do that. Flex for me. So we're just measuring our femoral tunnel. As always, it's 40 something, 48, 46, 44, 43. Perfect. That guide wire on hand again, thanks. There it is, beautiful. And flex up, guys. So we've got a 7 centimetre graft. So I'm going to aim for about a 25 sockets, as we said, docking inside the knee. Here, flex for me, please.
So Peter, in terms of your graft, you mentioned that you have an 8-9 graft, right? So you put 8 in the femur, 9 in the tibia. What's your thought process behind that in terms of size? And then also now the second question is going to be looking at the length of your graft. What is your length of your graft overall? And do you always do a 25 millimeter tunnel on the femoral side?
Yeah, also a great question. So I always put my, trying to replicate normal ACL anatomy that fans out on the tibial side. The length issue is just a little pump there is really important. The upside of adjustables is we can deal with a really short graft if we need to. Here we'll have 25 in the, pull that all the way out, all the way out, all the way out, all the way, all the way. So again, I don't like putting the reamer in the knee, just out to 90 degrees with any sort of deep flexion. So 25 in the femur, we've got 25 inside the notch, and you can bottom out with an adjustable on the tibia, so you've got to make sure there's not too much graft in the tibia. So I'm happy with that femoral tunnel position right at the back. In terms of graft size, I mentioned we'll go to the golden boy, and then we'll pass that. Yeah, tibial guide. Graft size, I'm a believer, collagen is important, so it's always 8 or above for me on the hammies. But I do use the bigger side on the tibia, obviously for graft passage, because I'm coming from the tibial side. So we're using an elbow aimer here. Just hold the camera there for me, guys. So we have, in terms of length, we're right on 40 there. We'll try and preserve a moderate amount of this stump here. Foot pedal there, guys.
So, Peter, you finish your tibial tunnel, then you will go ahead with the meniscus repair?
I will, correct. So that's where we are, pretty happy with that, right in the middle. Can I have a curette, please? Curette, perfect. So again, we'll just protect on the way in. I'll use my curette as a protection guide. And this is the ACL Samba, as I've been told by my South American colleagues. We can see there.
It's quite a fast one.
It is a fast one. I'm not someone with a lot of rhythm, so my Italian heritage didn't give me much of that. So we obviously want to make graft passage easier. I know it was mentioned, I think, by Anil, whenever I'm doing a patella tendon, I don't keep the stump, but I want to have nice graft passage, but we'll obviously try and keep as much as we can. So we're happy with what we can see there. We've got a nice little plug here for the tibia. We're just going to put the passing suture in the femur now.
Peter, would you change the position of your tibial tunnel if patient has got a hyperextension or depending on the type of hyperextension he's having, or your standard tibial tunnel is always same?
Yeah, I mean, I'm trying to replicate their anatomy in that centre of the stump is what I'm aiming for. That said, I certainly try and get as anterior as I possibly can, but I don't tend to move it around a great deal. If I have a hyperextender, for me it's graft choice that makes the difference that I'll be, oh that's fine, you can leave that there, that I'll be doing. So we've got our tunnels ready to go here. We're going to go to the medial side of the knee now.
Peter, if you're going to do a root repair, say you had a lateral meniscus posterior root tear and you're going to repair that, would you still make your tibial tunnel, ACL tunnel, or?
Let's put, just sorry, yeah. So if I'm doing a root, let's put that in with this. If I'm doing a root, I'll do my ACL tunnel, then I will do my root tunnel, and I always like it, for a lateral root, a separate tunnel. The only times I bring my lateral root into my ACL tunnel is in a multi-lig where I'm worried about the amount of tunnels in the knee, and then I'll do my root tunnel, then I'll pass my root sutures, then I'll pass my graft. So we're here on the medial side, and although his access is okay, I would like a little pie crust, so if we just have an outside shot there. So we're going to aim for a little menisco-femoral pie crust here, so we can see I'm on the superior side, just trying to improve my access ever so slightly, and I'm just placing a slight valgus force. It is interesting, I found that my fellows who are mostly from the UK don't do much pie crusting. I need to convince them that this is okay, that it's better to injure the MCL than to injure the cartilage. But I'm a big pie cruster. Any medial root repair, any ramp repair, even a lot of my meniscal debridement, we're very happy to do that. And we can see the increased access that we've got in a very controlled fashion here.
And what would you do if you suddenly hear a pop sound?
Then I'll say that I've done a really good job. I'm not worried, not worried about that at all. Even if I do that, I'm not going to brace, if I was just doing meniscal work. But obviously in this case where we're repairing, we will. Now we're going to use Fast Fix Flex for the back here. As we can see here, and I might just quickly switch. Can someone just show me the outside shot? For those of you who have not seen Fast Fix Flex, we've got a shot here, just how the bending works. So we can see, there we go there. So the normal curved is orange, the reverse curved is pink. This normal curved, the top part, you can bend inside this little socket bender. Then you have this little black triangle, and that can only be bent through the orange part of the device. It's also got this shroud, which allows you to insert it inside the knee if you want to. So really effective device. We've been one of the 4 centres around the world investigating the use of Flex with teams in the UK, Spain and the US. So for my low-grade ramps like this, we're going to have a look here at the back. We're aiming to get down into that nice inferior capsular tissue. Just hold the camera there for me. Deploy the Flex there. For those of you who haven't used Flex, it is a slightly different feel to the stand. Oh, that one hasn't worked. We'll do a different one. Slightly different feel to the Fast Fix.
So Peter, I'm going to back you up a second in terms of actual landmarks and how to do your pie crusting of your
Yeah.
MCL. Could you explain kind of where you're going, what you're feeling, and yeah.
Yeah, great question. So, yeah, hold the camera there. So I use the light to just have a look at the saphenous, because we don't want to place it through the saphenous there, and then feel that there's a little bit of gristle I feel with my fingers, that we can see that posterior part of the MCL, that I like to basically send my needle, and I use my needle almost as a knife to go back and forth. Now I go superiorly. I know Peter Myers, my colleague in Brisbane, when he pie crusts, goes inferiorly. I'm not sure there's much of a difference, but I think that's important there. But again, I think it's certainly something I'd encourage. I'll go to the reverse now, everyone to feel comfortable doing. So that first suture we can see there has just lifted up the meniscus slightly, quite nicely though. So we're going to switch to a reverse curved. The bevel here points the other way. So if you see this is pink, here the bevel goes the other way.
So you use all inside always for your ramp repair, or you prefer suture lasso sometime from the posteromedial portal?
Like I certainly will use a lasso if we need to with a high grade. I didn't feel this was high grade, camera there, so I didn't feel this one justified it, but if we need to, we certainly will go from the back. Do a lot of shoulder surgery, so using an Acupass or a lasso doesn't really faze me greatly, but important to be able to use both if needed. Something we mentioned in the examination, certainly for me, I think if there is a lockman that is out of proportion to the pivot, something we talked about a lot on fellowship with Andy Williams was that a lockman out of proportion to the pivot tells us that it's likely that the ramp is clinically significant and that we need to do something about it. And I think that's a nice little trick there. So happy with that one there. And I think we're probably going to put one more here now, curved again.
Peter,
Yeah.
so when you do visualize the posteromedial compartment through
Yes.
the notch, do you ever put a needle through the back and just separate that capsular tissue to see if there is an inferior extension, how far it extends out? Because when you visualize, you really don't know because the capsule is onto the meniscus there. But sometimes you just, with a needle, from the posteromedial aspect, you should be able to peel it off and you'll see actually the ramp is much bigger, which we don't get the same visualization through the intercondylar area.
Yeah, again, I think all very, very valid points. And certainly, I think the key is feeling comfortable that you've got sufficient visualization and peeling off the capsule and actually doing exactly what you describe, I think is a great technique. Again, we've determined that wasn't required here, but certainly feel like that can be utilized if necessary. So we'll have a look here now that we have our 3 anchors in. We're going to have a look at the back again now. And hopefully it's sort of a little bit harder to get through, and we can see we cannot see that posteromedial compartment anymore now that we're at the back. So very happy with how that's come together, which is nice. So we're going to flex up now. We're going to switch to the lateral side. We've just put an enormous amount of water on the floor there, so apologies guys. Hopefully we don't have wet feet. So,
Peter, this is Anil Ranawat.
hello Anil.
Hey, can ramps heal?
Can ramps heal? Yeah, again, I think we have to think about, well, does it matter, Anil? So I would argue that the importance of the ramp is to protect your graft in that first 3 months while your graft is integrating. Similar to the all-white bucket on the medial side. I'm always going to repair that meniscal rasp because the whole purpose of it is to prevent that windscreen wipering, that AP translation, while we're trying to have our graft heal. So my focus is to have it there, and even if at 3-4 months it hasn't healed, whether that be clinically or radiologically, my graft is integrated and theoretically it's done its job. Is that a controversial statement?
No, I mean, I would just say this, is that I totally agree with your Andy's point. Obviously, if there's more anterior translation, you know that's a real ramp. So your clinical exam helps to look at it. But I think you didn't really do a ramp repair. You did a POL plication, really. Because I thought that ramp was healed. You just dampened the POL.
Yep, I think, I completely take your point. I think there would be plenty of people who wouldn't have actually done anything to what we just saw there on the medial side because he didn't have a higher grade Lockman, and there certainly wasn't much of a valley there, so I think that's a very valid point. So I don't know if anyone has any ideas of this lateral meniscus here, but certainly my aim here is to, as I said, try and maintain as much of that lateral meniscal tissue as we can, and then we're going to go side to side. Does that sound like a reasonable option?
So Peter, we noticed that you're rasping the lateral meniscus, but
Yes.
you didn't do the same to the ramp. Why? How and why are you treating that differently?
Yeah, I mean, I think this is fairly avascular here. The ramp, I haven't rasped, but I would argue that even my pie crusting from the outside has stimulated, because I went around at least a moderate way around the back, a little bit of bleeding with my needle as well. So I convinced myself that my needle's doing my job. I mentioned blood clot. Certainly we're doing more and more blood clot augmentation, and I think it's worth considering. Now, I'm going to put this into the popliteus here. I'd like the panel to tell me whether they think that's a good or a bad idea.
That's ouch to me.
Yeah.
So how do you
I
cancel
do.
your patient? You throw this thing into you throw this fast-fix into their popliteus. How do they feel in the next 3 months, 6 months, 9 months as they return to play?
Yeah,
when they
so-
feel that pop in the back of their knee?
Yeah, I must admit, Cassie, I've not found that it's been an issue at all. Maybe I just don't ask them enough. We've got another 2 of those guys. Don't ask them enough. But the whole, posterolateral pain, I think, particularly at the hiatus here, that popliteus tissue is the best tissue I've got to try and stabilise this pretty tenuous lateral meniscus. So I want fixation in it.
Yeah, using a Novo stitch in such case would have avoided implant into the popliteus tendon, do you think?
To use the Nova stitch, yeah, no, absolutely. But as I said, I'm intentionally placing into the popliteus there because I feel that actually provides me better fixation in that slightly tenuous capsule.
Are you kind of over-constraining that because now you got this radial tear, which is just adjacent to
we've got
it?
another one of the orange ones. Got another orange one. Yeah, so I certainly want, as I go to plan, I want as much fixation as I can as I come across because the radial tear is going to be challenging, and you can see with the horizontal part coming the whole way through, this is going to be difficult for us to avoid suture pullout. So that's part of my plan, to constrain as much as I can. Now, I don't know if you can see what I'm doing here, but I'm creating an accessory medial portals. This is basically a transpatellar tendon portal to change my angle. I'll never switch portals completely because I think the big risk there is the vessel. So certainly we'll never put in anchors from the lateral side, but from this accessory central portal, still happy that my trajectory is going to be in my favour, as we can see here.
Do you ever consider looking at the MRI pre-op to look for any aberrant trailings of the vessels?
Yeah, I must admit I haven't, but I wonder how that would change my management apart from making me even more stressed than I normally would about a tear like this. But yeah, I think that's a great call.
Peter, I just want to stress the popliteus concept that you talked about.
Yeah.
The goal of surgery, the first rule is fixation.
Yeah.
I can make things look pretty, and if it falls apart by the time they get to the recovery room, you did nothing. So I think your construct here is exactly what I would do, and the popliteus is the best tissue you have in that corner of the knee, and I go to it and use it every single time.
There you go. Thanks, man.
But Anil, what do you tell your patients? Anil, what do you tell your patients, though?
I fix their meniscus.
Okay. What have we got left, guys? We've got whatever we need. So I think realistically we need another one here. So this is quite a large, again, it's fairly hay bale-like what we're doing here, but, I heard in the last talk we all know the importance of the lateral meniscus, and, we'll do whatever it takes to prevent this meniscus falling apart. So we've got lovely assistants helping me out there. Again, this one probably catches the outside edge of the popliteus as well. And then we're going to, in a moment, switch portals, and then we're going to switch to attempt at side to side using the Nova Stitch. For any of you who have seen Dinshaw's great video that is available on YouTube of use of the Nova Stitch, it's beautiful, like a lot of what Dinshaw does, but it's a great example of how the Nova Stitch should be used. So I'm pretty happy now in terms of what we've got fixation-wise on this lateral side. Let's work out whether we need one more probe before we switch. So I think we're pretty good there. No, I'm going to put one more here, guys, and then we're going to switch to the Nova Stitch. Thank you.
What would be your indication for inside out on the lateral meniscus?
Yep, so as we go further around to the body, I mean, I'd like to go on the other side of the popliteus. I'll switch to an inside out. Again, mentioning Peter Myers, he's come up with a lovely device called a Mini-Pass, which we use for our blood clot augmentation as well. And certainly that's been very helpful with our inside out suturing. But at the very back, inside out, I think is great, but it starts to get a little more scary. You can see I've gone to reverse curved here for my angle of the dangle, as we say. And then obviously as we come round to the front, we'll use outside in using needles, or for those of you who've seen the AcuPass Direct, that's also a great device to use. So I feel like we've achieved a pretty decent repair of the horizontal component now.
You have great visualization in the lateral compartment. I think your assists are doing a great job. Any tips or tricks if that lateral compartment's tight?
Yeah, it's sort of the worst nightmare, isn't it?
Yes, it does suck.
So for me, my order of events, probe, thanks, will be I'll do a little pie crust of the ITB, but that's often not that helpful because that's mostly in extension. I'll then do a little slide of the LCL, and then finally, if we're doing a lateral meniscus transplant and we can't get access, we'll actually do a Houston osteotomy where we take off the attachment of the lateral epicondyle and popliteus as part of an osteotomy. Have never done that as part of a meniscal repair, but certainly little tips. We'll get the Nova Stitch. Things like removing the side support, hugely advantageous, to improving that access. That 5 or 10 degrees is often what you need to improve that access. So here's the Nova Stitch in the knee. For those of you who haven't seen it, it's really helpful because the jaws sort of sit there basically parallel to the condyle and reach out the back. So I'm going to introduce the lower jaw into the knee, which we can see here. As I said, I've swapped portals. You have to be in the right angle. I'm going to grip this posterior part, pass, and we can see that little black line. That's where the suture comes out. I'm then releasing. And we've got a moderate bite there. And the beauty of this device is you don't have to then come out of the knee. I'm going to then move across here, and this is always the hard part, as we come across to this sort of root component. And then what we're going to hope is that that hasn't passed in a horizontal component of the tear. And so far it looks like we're looking okay here for our side-to-side component.
That looks great.
As long as it stays great, but so far I feel like we're doing okay. Yeah. And then we're going to...
What if the tissue quality is not good on the medial side? So what is your bailout situation in such cases for the radial tears?
Say that again, on the medial side?
This medial fragment, if the tissue quality is not good, there are chances of cut through. So what is your bailout situation in such cases?
Bailout on the medial side, then I'll go to inside out.
Okay.
And then do as many PDS as we can. We're just having an issue here where that appears to be a bit stuck on our Nova stitch. What's that? Just pull
Sorry,
it.
Peter, I know you're in the thought process,
there
but
it
could
is. No,
you
sorry.
clarify a little bit? So if your medial root segment is of poor tissue quality, you said
Yep.
you'd go inside out?
Yeah, I'll go inside out to stabilize the, basically stabilize the body root side. So I try and maximize the body root side, the body side, sorry, and again, have something to pull against, if that makes sense. Again, like a rip stop, create a rip stop and then pass my root sutures on the other side of the rip stop as best I can.
Yeah, that makes sense. Yeah.
Sorry, that was poor description before. So I'm seeing which one's going to be my post, and it's better reduction with that one as my post there. So we're going to artery clip, thanks. So I'll tie a slider here.
How much root remnant do you need so that you can actually throw a stitch like a Nova stitch through that?
Yeah, I think we're not far off the limit here, yeah? I think, you know, I say to my fellows, we need enough root to be able to get sufficient fixation, and often you only find that out at the time. And then if we don't get sufficient fixation, then we switch to a non-anatomic root repair, simple as that. And I'd much rather have a non-anatomic root repair with sufficient fixation than no fixation at all, albeit you know, slightly more dogmatic about the anatomic position.
So it's a more of a T-shaped tear. So you're going to address the horizontal component as well, or just a radial side to side is sufficient for you?
I don't know that we've got, as in another part of the, which horizontal component are you referring to? On the root side here?
The root side, yeah, root side I'm talking.
Okay, yeah, we'll have another look at that. But certainly the fixation, the reduction I feel like we have here at the moment, I feel like we're doing okay. So we'll cut that. Okay, we'll have a little look at that, little pump, thanks guys. Thank you, little pump of fluid for visualization there. So we're looking like we're pretty good. Now who thinks I need another side to side here? What's the vote?
I'm going to say you don't need it because it actually looks really
absolutely.
nicely approximated. The lateral side
Yeah.
can potentially heal. You got a nice big giant hole in the femoral condyle right there to give you bone marrow. And anything else you would do? Because I think we're coming on time right now.
Yeah, no, I think that's it. I completely agree with everyone. Less is more. So now we're going to go back and quickly pass our ACL graft. But from a fixation point of view of those menisci, we are happy. So we're going to go.
All right, Peter, thank you so much. And we appreciate such great work.
Thanks,
Absolutely
everybody.
fantastic.